on. Can you guys hear me okay? Bethany, you good? All right. Perfect. So today we're going to kind of talk about UTIs in kind of an all-encompassing sort of way. We do have quite a bit to cover today. One of the big things is going to be the 2016 AAP clinical practice guidelines for infants and kids 2 to 24 months. And then we'll also go into the diagnostic and therapeutic approach to UTIs in general, including our guidelines at Prisma Health. So first of all, as you guys know, UTIs are something that we see very frequently in both the inpatient and the outpatient setting. And so we're going to kind of talk about both of those things in both of those contexts, as we go through this presentation. But like the slide says, the overall prevalence in febrile infants with no source of fever is about 5%, and in older children even about 8%, which compared to a lot of other things we see is pretty high. So UTI is more of an umbrella term. So you could be referring to cystitis or just a lower UTI localized to the bladder, or pyelo, or an upper UTI. All right, first things first. I feel like this is probably the question I get the most from people about, okay, am I supposed to call it a febrile UTI or is it pyelo, especially in infants or in this age group? And a lot of that, so unless you have like imaging or something that says, oh, there is these spots on the kidney that show that it's pyelo or whatever, it's very difficult to kind of differentiate. And a lot of it has to do, the terminology, especially coming from my perspective as a hospitalist, is about billing and coding. And febrile UTI does not actually code to pyelonephritis. And so most of the time, if it's not like a straightforward, this is only a cystitis, then we call it pyelonephritis. So the E. coli by far is the most common bacteria that causes UTI in all ages. About 54 to 67%, depending on the study you read, accounts for the UTIs. We do see gram positive as well, but we'll go into that a little bit later. But Enterococcus being one of the more common gram positives, but E. coli, Klebsiella is more what we see in terms of gram negatives. All right, so let's just kind of talk about our general approach to a patient with a suspected UTI. So here are a few risk factors to always ask about in your history. Bowel and bladder dysfunction actually occurs in about 20% of all children in general, and then 50% of all children with a history of a UTI. So that's a huge thing to kind of ask about as you're taking a history on these kids with suspected UTI. And really, our treatment of constipation often will help prevent future UTIs. Another big thing is circumcised versus uncircumcised males. So the rate for uncircumcised males is about 4 to 20 times higher than for circumcised boys, whose rate really is very, very low. It's about 0.2 to 0.4%. It's also important to ask about history of previous UTIs. Have you been worked up for reflux? are they supposed to be on any sort of prophylactic antibiotic, which we'll go into a little bit more at the end as well. Or do they have a presence of an indwelling catheter, or are they someone who has to in and out cath at home? All of these things, are good to ask about. All right, let's see. So let's see if I can click on this. Tell me if this comes up for you guys, but there is a UTI calc. I personally don't use it very often, but I did want to point it out to you guys and let you know that it is available. So basically it determines the probability of a UTI in febrile children in this age group of 2 to 24 months based upon their clinical and lab results. So let's see. This might mess everything up. We'll see. Or it won't do anything. All right, just kidding. We won't talk about that. But if you guys want to write down that website and look at it later. All right, so clinical presentation. A lot of times in kids younger than 2, they come in with fever and really not much else. You might find a little bit of abdominal tenderness on exam, or really it's just this fever, no source, and they're a little bit fussy or something like that. In older children, it's a little bit easier to get more things that point to that in terms of, dysuria, frequency, urgency, whether it's abdominal pain, suprapubic pain, flank pain, that sort of thing. Sometimes even they could have some hematuria also that goes along with this. So in general, physical exam, always very important. It also helps too in terms of, kids with pyelo are often a lot sicker. Now, Dr. Stallworth, loves asking about some labial adhesions now. So don't forget that when he's like, what will set you up for a UTI? Always what he's looking for. So remember that. Phimosis, other GU abnormalities, masses, always looking for a sacral dimple. So very important things to look out for. All right, so let's go ahead and start on kind of the diagnostic workup, and then we'll go into therapeutic management. And now is when we'll start with the clinical practice guidelines from the AAP in 2016. So our first action statement is, so basically what this is saying is that if you have a febrile infant without a very obvious source that you feel like, okay, they're ill appearing, or for some reason, you do want to start antibiotic therapy, this statement is saying you definitely need to ensure that a urine specimen is obtained for both culture and urinalysis before you start antibiotics. And basically, as we all know, that is because you do not want a pre-treated urine specimen. And it also mentions in this statement that it needs to be obtained through cathing, because the diagnosis of a UTI cannot be reliably made through a bag urine, which we'll go into a little bit in the next one. So our next statement is basically about assessing the likelihood of a UTI, and going back to that little calculator I talked about earlier. So assessing the likelihood of the UTI, if it's a low likelihood, then it's saying, clinical follow-up. But what I think is really important about this action statement is that, if you determine that it's not a low likelihood of a UTI, then you've got 2 options. You can either go and, obtain the urine via cath for culture and urinalysis, or this is option 2, is a lot we run into when parents kind of give a lot more pushback in terms of cathing the kid. So what you can do is obtain like a bag urine. And then if the urinalysis suggests any sort of UTI, so, does it have positive LE or nitrites or something, then you go back to the family and you're like, okay, so we're going to have to go ahead and obtain a urine through a cath specimen. But if it's negative, then you don't have to cath them and don't need to be sending a culture and that sort of thing. So I feel like a lot of times we end up going this route, to kind of save them from the cath if possible. But sometimes, obviously, we can't always do that. Okay, so let's just go into, while we're talking about it, a little bit of methods of obtaining urine. So suprapubic aspiration, this is definitely something that has fallen out of fashion for obvious reasons. But, there are variable success rates. The perception, and maybe reality, is that this is a very invasive procedure. But, when you have kids with, severe phimosis or girls with tight labial adhesions, this may be your only option. But so I wanted to mention it because it does talk about it. Anytime it talks about cathing, it mentions this within the guidelines, but it's often something that we do not do. And then, bag urine. So, like we mentioned before, have a high false positive rate and are only valid when they yield the negative results, like we just talked about. So we can use this as a screening test before we cath them. And then, so catheterization, sensitivity of 95%, specificity of 99. And even with this one, even with the cath, the first few drops of urine should be discarded because they may be contaminated by bacteria within the distal urethra. All right, so our third action statement is about the diagnosis of a UTI. So in order to establish the diagnosis, we have to have both urinalysis that suggests infection, so whether or not that is pyuria or bacteriuria, that, as well as the presence of at least 50,000 colony-forming units of a culture from a urine specimen obtained through catheterization. So 50,000 through a cath. And then in terms of pyuria, like, are there, greater than 5 whites on micro, for example. And then I listed here just organisms that, we often will say are not considered clinically relevant urine isolates. So it's got to be of a uropathogen obtained through catheterization of 50,000. So looking at this, so leukocyte esterase is basically, a surrogate marker for pyuria. And it does help. We'll go into a little bit later of like asymptomatic bacteriuria, but this certainly helps differentiate between the two. Now, certainly keep in mind that there also can be positive in other things. So strep infections, Kawasaki is a big one. We always talk about like the sterile pyuria after vigorous exercise. So certainly, interpreting the positive LEs with caution in terms of when you have positive LEs and either a negative culture or no bacteria found in the urine. And so that's when you would call it a sterile pyuria. But the sensitivity in general of LE is pretty high. It's about 94%, whereas the specificity, for obvious reasons, is 72%, so a lot lower. as opposed to the nitrites. So nitrite is not a sensitive marker for children, particularly in infants, but it is pretty specific. So basically for nitrite, so most gram-negative enteric bacteria will convert dietary nitrates to nitrites and therefore cause a positive nitrate on your UA. Now, in order for this to happen, it requires about 4 hours in the bladder to convert. So basically, in kids that are not potty trained, you know, pretty much the whole age group that this, you know, 2016 guidelines is talking about, you know, you may not have time to sit in the bladder in order to do that. So if in a potty trained kid, an older kid who has negative nitrites, I'm paying attention to that way more so than I'm paying attention if the kid is an infant or smaller. And that's what it means by not sensitive marker for those with frequent voiding. And yes, so not all urinary pathogens reduce nitrates to nitrites. And like we talked about, so the gram-negative enteric bacteria versus, so which, you know, E. coli, Klebsiella, that sort of thing, as opposed to like Enterococcus, which would not convert. All right, so let's transition a little bit into talking about treatment. Let's first start off with like, why do we treat to begin with? So our kind of goals in general. So certainly we want to eliminate an acute infection, prevent complications, but a big one is reducing the likelihood of renal damage. You know, a missed UTI can often lead to renal scarring, which in turn, you know, can cause down the road, whether that be, you know, chronic renal disease or hypertension. And certainly you want to balance that with overdiagnosis, you know, overtreatment, unnecessary and expensive imaging. Oh, right. And so the last bullet point is basically about, you know, trying, like kind of like we talked about first in the first statement, is to make sure that if you're going to give antibiotics that you've already obtained that urine, because urine is rapidly sterilized after initiating those antibiotics. All right, so let's take a second real quick before we move on to the next action statement and talk about asymptomatic bacteria. So the key to distinguishing true UTIs from asymptomatic bacteria is the presence of pyuria. So, well, and the fact that they're asymptomatic, right? So when we find like a positive culture, you know, or bacteria in the urine on the UA with micro, you know, think about, okay, does this kid have symptoms? Does this kid have a, you know, any sort of setup for UTI, that sort of thing? But the big deciding factor is there pyuria there? And we do not treat asymptomatic bacteria. All right, so our clinical practice guidelines statement number 4. So, you know, when initiating treatment, obviously you're going to pick between, do we need an oral agent? Do we need IV treatment? And we base that a lot on our, you know, local antibiogram. And our spectrum app is very helpful for that. So, and it talks about the clinician should choose 7 to 14 days at the duration of the therapy. Now, we can, if it'll pull up, actually, I don't know if it will since my other one didn't pull up, but we can talk about our guidelines for Prisma Health of that a lot of times for just a plain cystitis, we can do 5 days of treatment. But most of the time, especially for pyelo, depending on which antibiotic you use, we need 7 to 14 days is usually the standard. So here are some options for, IV therapy or oral therapy. All right, let's see if this pulls up. Give me 1 second to see if this will pull up. Well, no, it will not, but maybe at the end, once I stop this presentation, I can pull that up for you guys. But so ASP and our infectious disease doctors have come up with 2 different guidelines for treatment in terms of depending upon age. And a lot of it, and it also goes over various, how long do you treat with certain antibiotics? Because, for example, like Cipro and Bactrim versus length of treatment of, say, like Augmentin or Keflex. So oral beta-lactams, we certainly do use them, but because they have a little bit lower penetration to the kidney and hence a higher risk of treatment failure in comparison, okay, to the fluoroquinolones and Bactrim, then we treat them a little bit longer. Do you do 10 days instead of 7 days, that sort of thing. But our guidelines go over that pretty well. Another thing to think about too is like which antibiotics, if they're excreted exclusively through the urine, a lot of times they do not penetrate the kidney well. So like nitrofurantoin macrobid. So you would want to use those more so for when you're confident that you are only dealing with a cystitis versus a pyelonephritis. So this statement is a little hard in that certainly with uncomplicated UTI, if the clinical condition worsens or fails to improve within 48 to 72 hours, is it because the antibiotic is not the right one, like you need to broaden it, or do I have like a renal abscess or something else that's complicating my picture? Now, I will say that the caveat to this is that pyelo can be very long and hard to treat. So there are times that, you go 4 or 5 days with persistent fever and that sort of thing before you're getting better and you don't have complications. So you kind of have to, it's certainly not wrong to, okay, let's get another ultrasound and look for complications, but also keeping in mind that you have to be patient with pyelo because it does often take a while to get better. So yeah, I sort of mentioned this before. So certain renal scarring can lead to renal dysfunction, hypertension, proteinuria, and then, end up perhaps progressing to end-stage renal disease, which is why we care so much about treating this. All right, so action statement number 5. So this is about our renal and bladder ultrasounds. So first of all, when we started doing more prenatal ultrasounds, this has reduced the prevalence of previously unsuspected obstructive uropathy in infants. So we often know some information before these kids are born and have their first UTI. But basically what this statement is saying is that febrile infants with UTI should undergo renal ultrasound to detect anatomic abnormalities that may require further evaluation. So you're evaluating the renal parenchyma, assessing renal size. So is there hydronephrosis? Is there hydroureter? Um, so I do want to make one quick statement that, um, you know, for example, I still think, you can go ahead and get this during an infection, but just think about how sometimes E. coli endotoxin can produce a little bit of dilation during an acute infection, which could be confused with hydronephrosis, or it's like pelviectasis. And so, just keep that in mind, having an abnormal, but I would still recommend, getting that renal ultrasound with the first febrile UTI. Because you're looking for, okay, do I have a setup in terms of vesicoureteral reflux? Do I have some sort of obstruction like a UPJ or UVJ obstruction that's setting my patient up for these UTIs? And then in terms of VCUG, so VCUG should not be performed routinely after the first febrile UTI, but it is indicated when it reveals hydronephrosis, scarring, or other findings. Like I just mentioned, that would suggest high-grade VUR or obstructive uropathy. So if there's a recurrence of a febrile UTI, it should be considered, but certainly look at the wording of this action statement, as it is not 100%, it's telling you exactly what you need to do. But basically, we often do not do VCUGs during the active infection because it involves catheterization, filling the bladder with like this radio-opaque or radioactive liquid, and then you're recording basically VUR during voiding. And so if the urine is infected, basically what you're doing is just splashing, infected urine back up into the kidney. So that's usually frowned upon. All right, so action statement number 7. So this is more about after you've diagnosed UTI, talking to parents or guardians about seeking medical evaluation for future febrile illnesses, to ensure that recurrent infections can be detected, quickly, therefore limiting renal damage, renal scarring, propensity for hypertension, that sort of thing. All right, so let's talk a little bit about prophylaxis. I feel like this is always a hot topic, always a debate, and still kind of remains that way. But this is from 2014. This is one of the bigger trials. It's one of the most, like, the randomized intervention for children with vesicoureteral reflux. So going over this a little bit more. So this was a 2-year multi-site randomized placebo-controlled trial, 607 kids with reflux. So 302 of them got prophylaxis with Bactrim, and then 305 were placebo. And this was, vesicoureteral reflux that was diagnosed after like a first or second febrile UTI. So basically what they evaluated for, the primary outcome was preventing recurrences of UTI. Secondary outcomes was the incidence of like renal scarring, treatment failure, resistance. So what they found was that prophylaxis reduced the risk of recurrences by 50%, but the occurrence of renal scarring did not differ significantly between the groups, which is why a lot of the debate comes up in terms of whether to do this, because, some people say, well, what I really care about is not necessarily the recurrences, but what they will end up doing with the renal scarring. So if it doesn't, differentiate, in terms of down the road, is it a benefit, especially when you consider antimicrobial resistance and other side effects of continued antibiotics. So they did conclude that, prophylaxis is a benefit, but to prevent one UTI recurrence requires over 5,800 doses, and does not reduce the rate of renal scarring. So certainly, depending on who you ask, you will get, different answers in terms of what you need to do about this. But so speaking of that, indications for referral to pediatric nephrology or urology, because they're going to be the ones usually that follow these kids with prophylactic medication. So do they have obstructive uropathy like a UVJ, UPJ? Usually you already know if they have posterior urethral valves. Or, are they reflux? Do they have renal abnormality? Impaired kidney function, hypertension, that sort of thing. All right, so a couple of takeaway points, and then we've got some questions that we can go over. So UTIs are a common cause of occult and serious bacterial infections in children. And actually, that's why, because they're so common, that's how we came up with, we used to call them, especially like in neonates, it's a part of the serious bacterial infections. But because they were more common, and some say, less serious, that's why we came up with the term invasive bacterial infections, that are just the term for bacteremia or meningitis, as opposed to the all-encompassing term serious bacterial infections with UTI. So like we mentioned, E. coli, most common cause of UTI. You guys can use that UTI calc I brought up, and let me know if you need me to re-give you that website, or you can Google it. Certainly a cath is the most accurate means of testing. Older children, it's a much easier to instruct to be able to use the clean catch. And then don't forget diagnosis. You got to have both, either evidence, pyuria and or bacteria with the presence of at least 50,000 of a uropathogen through catheterization. Look up those ASP guidelines. They're very good. And then, renal ultrasound, children under 2 presenting with the first time febrile UTI. Okay, so just a few questions here. I can't actually see the chat box, so if you guys want to, I'll read the question, and then if you want to either put it in the chat box and somebody can say it, because I don't know how to find it with this, or just unmute yourself and let me know what y'all think. So which of the following is the best diagnostic criteria for UTI? Is it greater than 100,000 colony forming units of a single uropathogen in an appropriately collected specimen, presence of pyuria, and 50,000 in an appropriately collected, positive LE, positive nitrites on a dipstick, or presence of pyuria and at least 10,000 of a single pathogen inappropriately? What y'all think?
E.
Yo, you're right. I feel like I've kind of beat a dead horse with this one, so I won't go over why that is correct. Okay, next one. 12-year-old with a history of spina bifida and neurogenic bladder requiring self-catheterization presents to the ED with complaints of fever for 2 days, Tmax 101. She does have some sore throat and abdominal pain, denies any dysuria, no foul-smelling urine. Here's the urinalysis, and your rapid strep returned positive. So which of the following is the best diagnosis based upon the following urinalysis results? So it looks like you got a concentrated urine 1025. You got trace ketones, small blood, but 3 red blood cells, negative nitrite, negative LE, no whites, many bacteria.
B.
All right, so asymptomatic bacteria, which can be common in these types of kids. This question does remind me that I did want to bring up too. So kids with frequent UTIs, especially this type of setup in this question, when they get admitted to the hospital, make sure that you go back and look at all of their old culture results, because a lot of times when they come in, empirically, you're going to start Rocephin. But if, say, oh gosh, okay, they've grown Klebsiella and E. coli and Enterococcus in the past, because Enterococcus is resistant to Rocephin, you may want to go ahead and start Rocephin and ampicillin while you await the culture, or you can hurry and get that gram stain and see if that'll help you out some with, is it a gram negative or a gram positive. But certainly if they've had UTIs in the past, definitely look up what they've grown. All right, previously healthy 9-month-old, uncircumcised male, brought to the clinic by his parents, 12 hours of fever. He's not had nasal congestion, cough, diarrhea. He's had 1 episode of emesis. Continues to breastfeed, had a normal number of wet diapers. 101.1 is his temperature, mildly ill appearing. No discernible focus of infection. So which of the following factors is most strongly associated with an increased probability of this kid having a UTI? It's kind of a little bit hard, but
E.
Sorry, I can't hear you.
Is it E?
It is E. Excellent. So certainly, vomiting can go with, gosh, does he have pylo, that sort of thing, temperature, but, truly having an associated with increased probability, definitely uncircumcised. All right. So a 6-month-old female is brought to the ED with a 2-day history of fever. She's not had vomiting, diarrhea, cough, congestion, no sick contacts. She continues to breastfeed and has not had a decrease in number of wet diapers. She's got a temp of 102.4. She's also mildly ill appearing, but interactive. No source of infection. A bag urine is collected and sent for urinalysis. SpecGrav 1015, trace protein, 1+ leukesterase, positive nitrites, 10 to 12 whites. So which of the following results from her urinalysis has the highest specificity for having a UTI? So specificity, what do y'all think? All right, nitrite. So this is also a good example of a question of, say you're on the boards, and I used to get really annoyed when I didn't read the question first and then I read this whole thing, and it's like, okay, I could have just looked at which of the following results from her urinalysis has the highest specificity. Now I still would skim some of the question, but this is a good example of like, okay, I just wasted a bunch of time reading that and didn't really need to.
Dr. Edwards?
Yes.
Since she's not potty trained and it was a bag urine, is that higher likelihood of false positive?
That is correct. Yes. 100%.
Okay.
And with the potty trained and the or like the positive nitrites or whatever. So a lot of times it's, helpful when it's positive, but when it's negative in a non-potty trained, it's not as helpful because of that whole time thing we talked about.
Thank you.
All right. So same 6-month-old. So urine culture, catheterization. She's not allergic to any medicines. She is breastfeeding normally, so taking good PO. What could you do for empiric therapy?
Cephalexin.
Yeah, perfect. So Keflex. So again, if this kid's admitted, it wouldn't be wrong, like, okay, let's go ahead and give her a dose of Rocephin. But if we're taking good PO, you can just stick with, you could have done Bactrim or Keflex. And And then the nitrofurantoin, I would be a little nervous about doing, especially in a 6-month-old, because I'd be worried that she does have pyelo and that would not penetrate the kidney well. All right, I think there's maybe 1 or 2 more. So a 4-month-old presents with a 2-day history of fever, not vomiting, is alert, no focus of infection. He is circumcised. He's cathed. Urinalysis shows 2+ leukocyte esterase, negative nitrite, 20 to 30 whites. No allergies, started on Bactrim. It grows 50,000 of E. coli susceptible to Bactrim. After being sent home, his mother's called and states that he is acting well, not had a fever in the past day. And then she is advised to have him complete the 10 days. So what is the following is the most important next step in management?
Renal and bladder ultrasound.
Done. Yeah, absolutely. So depending on whether or not, this is abnormal, you may do a VCG afterwards as well, but certainly the appropriate next step is a renal ultrasound. All right, lastly, 34-month-old, 1-day history of dysuria and urgency, no fever. She received a diagnosis of febrile UTI at 20 months, normal ultrasound. She had a second UTI at 23 months. VCG was normal. She had a third one at 30 months and was afebrile. She also has a history of chronic functional constipation associated with fecal incontinence. On exam, she doesn't have any CVA tenderness. The vulvar area has some mild erythema. A clean catch, positive for LE, nitrite, and few epithelial cells. It grows 100,000 of Klebsiella in addition to 7 days of antibiotics. Which is the most appropriate next step?
Constipation management.
You guys are 100. Was that Jaya laughing? All right.
Was it even unmuted? Can you hear it from there?
Oh. All right. So that is all I've got. Does anyone have any questions?
I have a quick question. I don't know if you talked about it, but like indications for hospitalization for treatment versus outpatient management.
Yeah, I love that question. Is that Cecilia?
Yes.
Okay. So a couple of things. One, a lot of it has to do with whether or not they will tolerate PO. So, do they have normal vitals? Are they going to be able to take the medicine PO? Is kind of a big deciding factor usually for me. Are they clinically dehydrated? And I do feel like, we do often admit perhaps more than we should sometimes, but a lot of times with kids, and because of like the sequelae down the road of untreated UTIs, we'll err on the side of admitting. But certainly there's, majority of people you do not admit. Does that answer your question? So,
Yes. Thank you.
Yeah. All right. Any other questions? I'll get back on my video so we can see you. All right. Well, you guys know where my office is in case you have more questions.
Thank you, Dr. Edwards.
Thank you.
That was great.
How do I get in?
Thanks, Holly.
Thanks.